Good evening, everybody. Welcome to the Prostate Forum. We are honored to have Dr. Afshar, who is a medical doctor with Urological Associates, San Fernando Valley Urological Associates in Tarzana, California. That is the southwest San Fernando Valley. He is an expert with something called TULSA-PRO. TULSA-PRO, if this is new for you, is a process of combining MRI with transurethral ultrasound to burn up cancer and do it precisely. TULSA-PRO has been an exciting thing here at Prostate Forum. This is at least our third presentation, and there's usually a lot of good questions that come out of it. Dr. Afshar is an expert in robotic surgery with advanced training in complex urologic cancers of all kinds, not just prostate cancer. He uses minimally invasive techniques such as TULSA-PRO. He did his residency at Cedars-Sinai Medical Center, that's in West Los Angeles, and continues training with a fellowship in advanced endourology and robotic surgery at USC Norris Comprehensive Cancer Center.
Hi guys, how are you doing? My name is Ali Afshar. Thank you for the introduction. Thank you for having me in this meeting. But I'm a urologist. I did fellowship, and my main focus of my practice is actually prostate. These includes BPH symptoms. I treat them with multimodality treatments as well as prostate cancer, and these include robotic prostatectomy. I do TULSA-PRO, which is one type of a focal therapy. I also perform other types of therapies, including focal one, which is a different type of a HIFU modality similar to TULSA, but in a different method, and also nanoknife, which is application of electricity to the cancer. So we are going to talk about the TULSA-PRO today. All right. So this talk might be a little bit of a longer presentation with some clinical data which not pertain to majority of patients, because I mean obviously some of these are directed toward clinicians. However, this is a good overview about the how this procedure works and prostate cancer itself. TULSA-PRO, I came to California about 2 to 3 years ago, and we started doing the procedures here in San Fernando Valley area, West Hills specifically. Thank you for the introduction earlier on, which you mentioned where I trained. So how it works is that this treatment is done by two folks. One of them is the urologist, and is a combination, is a collaboration that is done with the radiologist as well. I, as a urologist, place this instrument through the urethra into your bladder, and then this instrument that we use has this little elements on it that cause the ultrasonic sound to go up, and this results on causing heat, and that's the way we treat the prostate cancer. Now, these 10 parallel crystals that focuses the ultrasonic sound with high frequency into this area are located at the portion which we utilize the MRI to look at, to put this across the prostate and treat the cancer. And this instrument is attached to a robotic arm that continuously turns around in the prostate. Basically, you're able to treat about somewhere at about 360 degrees majority of the prostate. Also, when you hit the prostate to kill the prostate cancer, you got to make sure that you're not damaging the rectum. So there is a cooling rectal cooling device that we put in to bring the temperature down to avoid damage to the surrounding organs, especially the rectum. So the unique thing about this procedure is that is done inside an MRI machine. And the MRI machine, every few seconds, it takes a picture. And what we are seeing in this MRI machine, what is unique about it comparable to other procedures, is that we can see how much heat we apply to the prostate. And the minimum heating temperature that you need that is proven to cause destruction of the cancer cells and to treat is 55 degrees of Celsius. Um, the unique thing also, in addition, with the MRI, we can control how far we are hitting the prostate, and we can avoid things like such as your nerves that helps with the erections, and also avoid sphincter because we see this under a live MRI. This is unique to this procedure because other procedures that you can do focal treatment, you don't have that capability. For regular HIFU that is most common that came years ago, it's done by an ultrasound. You cannot see the structures, obviously, as well as you can see on the MRI, and also the ultrasound alone does not show how much heat you apply to the area. Did you treat that area? So this is what is very much unique to the TULSA itself. This is the other great thing about the TULSA. TULSA can have multiple different modalities and options that you can treat. One, you can just do for BPH, for prostate that is enlarged. You can do as initial studies that have shown that they are able to reduce the prostate of a 90 gram to less than 10 grams, which this is a pretty effective procedure for that. It takes a longer amount of time to do it, comparable to if you're doing a certain procedure at times, but it's very effective. It resolves the urinary symptoms. Other applications is a whole gland ablation of your prostate. If you have multiple areas of cancer that is throughout the prostate, you could treat the whole gland. And this is much better than other modalities because, number one, with a regular HIFU that you use the rectal probe, you cannot really treat the anterior aspect of the prostate. If there's tumor over there, TULSA will give you that capability because it's done through the urethra inside out rather than outside in from the rectum. You could treat just the area of cancer, leave the rest of the prostate alone. You could treat low risk prostate cancer and BPH symptoms together. Sometimes people get radiation therapy, and you can use TULSA-PRO to treat the area of recurrence after radiation failure that comes back. So it has a variety of options in a wide spectrum of patients that you can utilize this, while the other focal therapies are limited in treatment. The initial study that came out, they called it a TAC trial. This was the one that got the allowed the TULSA to get the approval for doing procedures in the United States in FDA. This study was done in 13 sites, multiple countries, and the primary endpoint was PSA reduction, which is the most important thing that we want to see when you treat somebody with focal therapy. Minimum drop in the PSA that you're looking at is about 70 to 75%. That's when you feel good, is that, okay, the treatment that I did, it appears to be effective, and that's where you want it to stay. So that's what they did at 1 year. They look at the PSA, and also they look at the secondary endpoints, meaning everything else that can come after that that could be beneficial. One of them is the prostate reduction in size, which is like as if you're treating the BPH. The smaller the prostate, the better you're peeing. That donut hole is much better. You have much better urinary symptoms. Also, they looked at it at biopsy of 1 year to see if there was any recurrence and what was the grade of the prostate cancer, and multiple other endpoints. What they saw is that the PSA reduction with this particular procedure was durable at 5 years, meaning that prostate PSA that went low stayed stable, stayed around the area that we wanted. And that's what you want, because if the PSA starts rising, then you worry about if the prostate cancer recurred. What do we do? How do we treat it? Those are some of the things that come along when you follow the PSA. And the way that we follow the PSA after focal therapy is very similar to how you do it for radiation therapy of the prostate. What they saw is that the PSA reduction with this procedure was even greater than some other focal therapies, more than almost to 96%, and 90% of those sustained at 5 years. This is pretty good results when we talk about the focal therapy. Um, so basically, as far as the size goes, there was about 90% drops in the size of the prostate, and the MRI, negative MRI was 96% negative predictive value, which is that's every time we offer a procedure to the patient or a lab test or a test that we do, we want to make sure that the negative predictive value is the highest level possible. That's when you know that your test or your treatment, this is valid. This is a good thing to do. These are some of the oncologic outcomes at baseline and 12 months. Prostate cancer is broken down into 5 groups: grade group 1 up to grade group 5. Grade group 1 is a low risk prostate cancer. Most of the time, we can observe it. We don't need to treat it. But however, for certain patients that they're uncomfortable with having prostate cancer in their body and also they have urinary symptoms, we can treat them focally without causing more morbidity by removing the prostate or causing other problems with radiation therapy itself. In this situation, grade group 2, which is equivalent to Gleason 3+4, or what they used to call as intermediate favorable risk, these patients were treated and no significant disease found at 1 year in 80% of men. But later on, at 5 years, some of the patients, 21% of them underwent treatment. But that is similar to patients that they go under robotic radical prostatectomy, they receive radiation therapy. There is always a probability of recurrence. The higher the grade group or your Gleason score, you have a higher risk for prostate cancer recurrence. Let's say somebody has a Gleason 4+3, which is unfavorable intermediate prostate cancer, at least in 3 cores by 5 years, they have somewhere about 15% chance of failure, even if they had the prostate completely removed or they received radiation. So this is somewhere around the same ballpark. TULSA-PRO, the good thing about the focal therapy or TULSA, if you're going to treat even the whole gland, is a single procedure. Radical prostatectomy is a single procedure, while radiation therapy is multiple sessions for weeks, sometimes up to 9 weeks, sometimes 5 weeks, depends on what modality that they use. I'm not going to really go into details about this adverse events. Some of the adverse events that we saw in the study that is actually good to know. There were no, some of them urinary tract infection. Some of the ones that we see immediately is GI discomfort, which goes away. However, overall, in any sort of a focal therapy that you do, which a paper came out years ago, that looked at thousands of patients that were done in Europe and other locations. And TULSA, actually, the data that we collected was somewhat better as far as the outcomes comparable to other treatments. However, every time you treat somebody with focal therapy, you discuss the risk of erectile dysfunction, which can be up to 20%. You have a risk for urethral stricture, meaning the scar tissue that happens inside where you urinate from. That's about 2.6%. And there is a failure that originally in some papers that they had published up to 26%. However, that paper was pretty much faulty. There were a lot of characteristics of the patients that underwent treatment were missing. With TULSA-PRO, what I liked about this is a modality is that this is very well documented. We are keeping track of what patient gets what treatment. We have actual imagings available, and it's not like, oh, we're just going to include everybody in there without being able to break them down into what the characteristic of the patient that they had. Also, what is important for males, for us, I mean, personally, I say this, if I go under any treatment for prostate cancer, I like to be able to keep my erections intact. I like to be able to not to be incontinent. I like to get treated and have the best outcome possible, and just keep my life as it is, but also treat the cancer. So focal therapy provides that. TULSA-PRO provides such an outcome. We have been working on to improve the technology. How can we do more to avoid recurrence? And there are certain things that our genius team, our PhD folks, and our physicians are working on to try to avoid this. But some of the things that may render a person to be unable to treatment include it could be calcifications that might be in the prostate to shield the treatment from being heated up to the 55 degrees and killing the cancer, but also calcifications may put you at risk for reflecting back the heat, causing damage to surrounding organs. So these are some of the things to keep in mind. This slide, as I had mentioned before, you can treat the whole gland, as you see the picture on the right side, that they decided 360 degrees, they treated the cancer. This patient could have had multiple diseases. So this capability to treat it. And the colors that you see, the red, there is an index temperature that we look at when we're treating the patient. Or you can do a focal treatment or a hemi treatment, meaning the only area that was biopsied was positive and we could see it, we could see the area, that's where we treat with just that location alone. And sometimes we just do a subtotal. It's not complete treatment. We leave the nerves intact to ensure that the patient has a higher probability to gain their erections back, because we know there's no cancer there, is not going to put the patient at risk. Now, who are the patients that they are good candidate to undergo treatment? These patients may include group 1 prostate cancer, that's 3+3. A lot of times that we do active surveillance for those patients. However, there's a certain category of those patients, if you have many cores positive, then probably observation is not the best, because it's a high volume cancer. The criteria for active surveillance was 3 cores positive, less than 50%, and a PSA of less than 10. Sometimes you're pushing the envelope. We watch those patients, but in reality, about 30 to 40% of those patients they progress to treatment within the next 5 years. Other things that can happen if you have Gleason 3+3, some of the physicians, your urologists may send the samples for genomic tests. These may include certain tests like Prolaris or Decipher. And if those tests, despite having grade group 1 prostate cancer, put you at intermediate risk or high risk to develop a metastatic disease for next 10 years, then we recommend consideration to undergo some sort of a treatment. Other category of patients in the Gleason 3+3 or low-grade prostate cancer includes the patients that have prostate symptoms. They want to treat the cancer, not to worry about it as much, but also relieve their urinary symptoms. That's an option to do TULSA-PRO. And one other nice thing about the TULSA-PRO, comparable to other modalities where you utilize for focal therapy, is treatment of larger glands. HIFU, which is transurethral, is limited to prostate size of less than 50 grams. However, with the TULSA-PRO, initially came out of 90. However, you can manipulate your instrument to treat a larger prostate and get the good treatment surrounding area, while the other modalities do not let you to do that. The sweet spots for treatment of focal therapy, what it is. Nowadays, when we have meetings, we always talk about, if we can show the treatment and effectiveness in patients that they have Gleason 4+3 or grade group 3, that would be the best patient to treat. However, we are doing intermediate disease 3+4, 4+3, all of them are viable for treatment. This could be one area that is positive for cancer. It could be bilaterally that is positive for cancer, small or larger volume. If you're going to get high food treatments with focal one or Sonoblade, if you have multimodal disease, they probably tell you this is not the best treatment for you because it's very hard to treat it with that kind of a mode of treatment or instrument. There has been situations that the patients with a higher risk prostate cancer opted to undergo treatment. These patients include patients that have Gleason 4+4, 4+5, or any combination with the 5. In NCCN guidelines in the United States for those patients recommend surgical removal or radiation therapy. But personally, I've had success with patients that have had high risk prostate cancer. We are 2-3 years out and their PSA remains very low, no sign of cancer on follow-up MRIs. So there's something to say it. One thing that would exclude a patient from receiving any therapy is that if the cancer is growing outside the capsule of the prostate, probably not the best option to do so. As you can see over here on the slide, the screening area, we got to make sure that the calcifications in the beam path are not that large, less than 3 millimeters. The PSA radius is 3 centimeters. Radius meaning from the middle of the urethra, when you measure it to the capsule, no more than 3 centimeters. And also, we got to make sure that there's no extracapsular disease, like either growing outside of the capsule or has gone to the lymph nodes. You don't want to do focal therapy for those. Other treatments that we can use are the patients that had radiation therapy and they unfortunately have biochemical recurrence. We can utilize the MRI TULSA for the treatment. All right, so this is a personal patient of mine. His Gleason score was 4+5, and he had some calcifications. I performed a procedure to remove some of the calcifications in the area because the patient was adamant about only wanting TULSA-PRO, accepting the risk because of the degree of his disease that he may have a recurrence, higher probability. However, we went ahead and did the treatment recently. After the TULSA, his PSA dropped from 6.7 to 0.67. At 6 months was 0.5. And most recent PSA that I got, which is a few days ago, I did not include it in the slide, was 0.55. So it's remaining stable. He's not on any medication. He's happy with his urination. His erections are intact. He feels this is the best treatment that he had. I'm happy for him, and I hope that it holds. We'll see what happens with that. All right. You could see the video of what was the area that we were planning on treating. All right. As you can see, this is a live action of what the MRI does. Inside the MRI, we see the dial that is going clockwise, and you see the temperature change. That temperature change, you want to reach the capsule, the area of the treatment that you want to do so that those pixelated different colors represent a different temperature. And this procedure was done 360 degrees on this patient. And as you can see on the last slide with the multiple images on the bottom, this is the image that we obtained after the treatment, given contrast. You see the area that is black, that means that area was treated because there's no contrast going to that area. The vascularity is gone. The tissue has been destroyed. This is what's very nice, that immediately we can see how well we treated the prostate itself, the prostate cancer. This is another patient that I had. His PSA was 13.3. He had a PIRADS of 5 lesion. There, when we say PIRADS of 5 or a PIRADS of 4 on an MRI, depends on the size of the lesion itself. It doesn't mean that PIRADS of 5 definitely is cancer and PIRADS of 4 it is not. It's just based on the size. But there are multiple, they call it multi-parametric MRI because we look at different modalities. That increases the suspicion for prostate cancer. He underwent prostate biopsy by a colleague, and his Gleason was diagnosed with Gleason 3+3. There are a couple of things to look at this. With the old way of looking at the degree of disease that the patient has, his PSA is 13. So although it is 3+3, he's not low risk prostate cancer, he's intermediate risk prostate cancer. To ensure that this patient is a good candidate for active surveillance, because that's what he was thinking, or we got a Decipher genomic test. This Decipher test looks at certain things that may represent a risk for prostate cancer to advance, metastasize, and cause problems. These came out to be as intermediate disease. When you have intermediate disease, it means recommended to at least go a single modality treatment for the prostate cancer rather than active surveillance. What we did is that we treated the prostate, the whole gland. We spared the other right-sided neurovascular bundles for the erections because of the location of the treatment, which was on the contralateral side. At 1 year, I got an MRI of the prostate. It showed an area that could be suspicious. Biopsied, it was negative. Prostate size by half at 1 year. At 2 years, currently, his PSA holds at 0.44. That means successful treatment. I don't have any suspicion that the prostate cancer is back. If there is any prostate cancer, it's not doing anything for us to proceed with any other modality of treatment. Another example of a patient that I did. This patient, most important thing for him was to keep his erections intact. It was very important for him. It was a 40-gram prostate. When we did the biopsy is similarly to what I had mentioned before. PIRADS 3 at the apex was 3+3 disease. His genomic test again became intermediate. I discussed the findings with him. He wanted to go under treatment and keep his ejaculation intact, as well as his erections. So we spared those. At 1 month was 1.05. I have his 6 months follow-up, which is 0.5, and it's holding. He's very happy. He has his erections immediately post-op and has no issues with his continence. So another success story. I give you another example to you. This patient had a PIRADS of 5, meaning a larger lesion more than 1.5 centimeter at the apex of the prostate, which was near the sphincter, but not quite a bit. On the left side, that he had a similar disease, biopsied him. He underwent treatment. We spared the right-sided neurovascular bundle. He kept his erections intact. His urination is better than ever. And he is holding. This is a 3D model of that prostate that I created. Whenever I treat a prostate cancer, I create a 3D model just to know where the tumor is located and what I need to do. This are the neurovascular bundles. This is seminal vesicles where 85% of your ejaculate comes from. This is prostate, urethra, and those 2 red balls you see, those are the cancer spots. And this is the bladder, and those are your veins. 1 year after the TULSA, there were no MRI lesions noted. I got a 1-year MRI. The prostate was measured around 15 grams on the MRI, which is not definitely accurate. I would have to do a transrectal ultrasound. No urinary complaints. PSA currently at 2 years is 0.78 and has not changed. Do you guys want me to talk about the jet about the captain trial or no?
Yes, absolutely.
Okay,
Talk about it. You got
so
a trial, talk about it.
yeah, so this trial is a very unique trial. There are no trials out there comparing to actuality of actual to how focal therapy compares to removal of the prostate head to head. This has never been done. All these focal therapies that have been out there for 10 years, 15 years, 20 years in the market, and people are developing it, they've never did a study to look at a head to head. So this is a very unique study. We are enrolling currently for patients that they have intermediate risk prostate cancer. Majority will be unfavorable intermediate prostate cancer, 4+3 in the study. And we comparing those patients and randomizing them based on a method to one arm will receive radical prostatectomy, the other arm will receive TULSA-PRO, and we'll see what the outcome is throughout the years and accumulate data. I think this is a pretty genius study. This study looks at not only what your PSA is going to be, if you have recurrence or not, but also the length of the penis, which may matter for some to a lot of males. I mean, I can't say that no, there's no male that do not care about the length of their penis, but with radical prostatectomy, you lose about 1 to 2 centimeters length, while the TULSA-PRO, hopefully that will not happen, but that's time to see what the results are. The studies breaking down, as I mentioned to you, the 1 year safety, the path-free rate, meaning there's no incontinence, and they're having erections that are sufficient for penetration. And at 3 years, we're looking at the patients to see if they require any other treatment, they stayed cancer-free or not. And this is done internationally in multiple different academic institutions. Some of these institutions, as you can see, Yale, Yale is doing that, UT Southwestern, Johns Hopkins, and we have a few studies going on in actually California, Southern California, which includes RadNet. I'm part of this study, and a few other colleagues that are doing it around the area. The eligibility area, the criteria for this study are the patients that they're between ages of 40 to 80 years of life. For prostate cancer treatment, we got to ensure that they have 10 years of life expectancy or more. They are, as I mentioned, favorable, unfavorable, intermediate risk. Their PSA is less than 20, and those are the patients that they never received any treatment, and they're amenable to say, okay, if I get randomized into this arm, I'll go through TULSA-PRO. However, if I need to do a robotic radical prostatectomy, I'm not going to say no to that. So I will be signing up for both of them. The exclusion criteria are the patients that they cannot receive MRI. This could be due to older pacemakers. Their tumors are more than 3 centimeters. There's calcifications throughout the prostate. They continue to have multiple infections, prostatitis, and just a few other criteria. I think we could hold off on this part, the rest of it, because those are not well done slides. There's some data that I cannot show the public about this. Any questions?
Is there any way to get rid of calcification in the prostate? From what I understand, doesn't that, I mean, it can be mistaken, I thought, cancer, and it increases PSA, doesn't it?
So no, so the calcifications do not have any impact on the PSA itself. There's an area between the prostate comes from 4 areas. These areas include peripheral zone, transitional zone, central zone, and fibromuscular zone. Between the areas of the transitional and the peripheral zone, because of the secretions, this may turn into calcifications. Calcifications could be any location in between these 2 areas. And what the calcification does is that, as I said, it shields the heat from going beyond that area and sometimes reflected backwards, which may cause to the tissue that you are beaming out of. If you're doing from rectum, you may damage the rectum. If you're doing the urethra, you may damage the urethra. So that's some of the things that can happen to it. But some colleagues are using transurethral resection of the prostate to attempt to remove this calcification. I use a tool called aquablation, which there's an ultrasound, transrectal ultrasound I put in, and I try to chase the calcification around the area that I believe that the cancer is located. So far, I've had good success with doing this, but that's possible.
Very interesting. So it's easy to confuse TULSA-PRO with other thermal ways of treating cancer. How does TULSA-PRO compare, say, to HIFU?
So TULSA-PRO is essentially HIFU. That's similar to each other. One's done through the rectum and one's done through the urethra. The one that is done through the rectum, that one goes outside of the prostate to inside. There are certain exclusion criteria for that. As I mentioned before, something like calcification, bowel disease, a thick rectum. Those are some of the things that may cause certain damage that would cause a lot of morbidities and problems for the patient. But both of these modalities, they use frequency, high frequency, causing heat and damage the cancer cells and treat the cancer. Like I said, the limitation with the transrectal way is that it's not a good modality to treat the anterior aspect of the prostate. It doesn't reach it well. You have to go through the urethra, and sometimes this increases the risk for urethral strictures. So it's not the best way. And also there is a limitation in size of the prostate that should not be more than certain size because you cannot reach the temperature needed to treat the cancer. So that's HIFU. TULSA is done through the urethra, which is inside out. Also utilizes the MRI to help mapping the heat, avoiding the structures. You could see the neurovascular bundle. So there are certain advantages to the TULSA that the focal one doesn't, like focal one or Sonoblade HIFU do not have. But both of them have been shown to be effective for treating prostate cancer as long as you choose the correct patient for those. There are other modalities such as cryotherapy, which basically freezes the prostate to a high degrees of Celsius below negative temperature, and that causes the destruction, except there's some possible complications such as urethral fistula, which can be debilitating and requiring certain surgeries, even bowel diversion, because it's kind of difficult to fix. But that has been used effectively. There are non-thermal treatments that you can do. There's laser ablation. There is one that is out there. There is another one called nanoknife, which uses electricity as high as 3,000 volts to apply between an area of the cancer, causing putting little holes in the cancer cells, which results as a cancer death, cell death. That's another modality.
Very interesting. Are you talking to Kaiser Permanente about this method?
They are aware of it. I believe that the Procept have approached them, and also RadNet. I believe that they're being approached, but I have not personally talked with them.
Okay.
I have a question. My
Hi, Bill.
PSA has been 0.06 now for close to a year.
Okay.
My prostate is still growing. What causes that?
You had a treatment for prostate cancer or no?
Yeah, I've had treatments. I'm using Erlita, that particular product, and I had for my sacrum, I had 10 rounds of radiation.
10 rounds of radiation. So you're still on androgen deprivation therapy?
I'm sorry, say that again?
You are still on androgen
Yeah,
deprivation therapy.
yeah,
Okay,
yes.
so 0.06, what they're obtaining off of you is called the ultra-sensitive PSA. Usually anything less than 0.01, meaning that is undetectable. I
Hmm.
don't, I have a hard time to say that your prostate size is growing because your testosterone, you're basically had a chemical castration. What
Hmm.
causes the prostate to grow in size is testosterone. Or if there is no food to it, then it wouldn't grow. However, if it gets into a situation where your prostate cancer does not respond to androgen deprivation therapy, which you are not in that situation, based on what the PSA you're telling me, that's called a castrate-resistant prostate cancer. Sometimes they lose control and start growing without even the testosterone being there, but that's very rare.
Yeah,
Or do you have urinary problems?
I was urinating a lot, okay, and then all of a sudden, I've been my urine's been tested for uric acid about 5 or 6 times, and it hasn't come up that there's anything that
Okay.
like that. And then they gave me this particular capsule that
Okay.
turns your urine from yellow to blue, and then all the pain and the urination went back to normal. But I am using a catheter, on certain occasions, just so I sleep through the night. Is that good or
Okay.
bad?
Well, I mean, there are many different ways of treating your situation. So what you mentioned is that you took Urabel. Urabel is something that takes the pain and the discomfort away for the urinary tract and makes sure urine blue. But if you're not emptying your bladder well, probably your prostate might be even obstructing.
Okay.
But also you had radiation therapy. Radiation therapy, what it does is that it causes your prostate tissue to become very hard and dense.
Mm.
So it's not that pliable. It doesn't open up as the way that it should, as you want to empty your bladder with a strong urine. So some physicians, when they have those patients, they go in and they do the what you have heard that is called TURP, transurethral resection of the prostate. They take a few swipes, they open up the passageway, you should pee better. But
Mm.
also there are other things. For frequency, which is that's irritative symptoms, that can happen if you have urinary tract infection, if you have overactive bladder. As we males age higher, we develop unfortunately, overactive bladder is more common in us. But also you had radiation. Radiation can cause inflammation of your bladder.
Mm.
Some people experience what is called a hemorrhagic induced radiation cystitis. And that's something ongoing that may cause bleeding, may cause worsening of urinary symptoms. That
Yeah.
can happen. Usually, if my patient comes in and sees me and they have a urinary frequency with after radiation therapy, sometime after radiation therapy, first, I got to make sure that they're emptying their bladder. So I start them on a medication like Flomax to open up the passageway. I
Mm.
put on scheduled voiding. I try to have them double void. As long as they're emptying their bladder, I can try certain medication that stops the spasms of your bladder. These
Mm.
include medication like mirabitric, Gemtesa, which is a beta-3 agonist, doesn't cause constipation or dry mouth, or anticholinergics such as ditropan, oxybutynin. So some of those can help you. If those don't help you, you're able to empty your bladder. You can get even a Botox injection into your bladder. It just depends.
Um, they did say that everything is down. Like there was a little nodule of cancer in my lung. No one considered it a major concern. It was reduced by 25%. The lymph nodes are all down and whatnot. But they also said that even though my prostate did grow, and I should know this better, the intensity of whatever it was shooting out to like feed the other areas was reduced by 25%. So it's the intensity of the prostate um, is much less, they said, than previously.
Intensity of your prostate. I'm sorry. I'm kind of missing what you mean by intensity.
Well, I I guess sending out whatever it sends out to fuel other areas in my body
Yeah.
with cancer.
Oh, so look, Your two things. I'm not worried about sending any, like right now in you, if you had a PSMA scan, I don't see why would they even get any imaging study on you when your PSA is so low and is undetectable, essentially. That's what I would call it. The
Right.
only time I get a study to see if somebody has a metastatic disease is their PSA keeps on rising. If you have radiation therapy, they look at 3 consecutive rises, or if it rises by 2 points. Then you
Okay.
get this PET scan to see if there is anywhere else in your body, if there is a recurrence. Most of the time is at the prostate level, not elsewhere in your body.
Hmm.
That's what it is.
Okay.
And when you're talking about the prostate growth, it's not usually the growth of the size of the prostate, but the inside of your prostate is probably blocking you.
Oh, I see. I see.
Okay. It's a mistake that people say, oh, you have an enlarged prostate. That's a mistake. Your
Okay.
large prostate does not indicate you have urinary problems. Somebody can have a 400-gram prostate, very large prostate, but no urinary problem. Somebody can have a 25-gram prostate, horrible urinary problem.
Oh, I see. I see.
The size is a mistake by, it just makes it simple to discuss it with
Got it.
everybody, but that's not the way it works.
Thank you. Thank you.
You are. Any other questions, guys?
Doctor, how does the treatment work with theranostics type treatments?
I'm sorry,
How does the treatment work with theranostics type treatments?
theranostic. I'm sorry, can you explain that to me? I'm sorry, I just don't know what you mean exactly.
It's LU-177 or Pluvicto in the US.
I do not know. I cannot answer that question for you.
Okay, thank you.
No problem.
How does treatment with TULSA-PRO compare in cost? Is it covered by insurance? Sounds like it'd be a lot less expensive than radiation.
Well, you can go back and forth. Right now, at the moment, most institutions that they're not part of a university, they are there is no insurance does not cover the TULSA-PRO. However, if you look at all the things that comes from radiation therapy that you have to deal with, the time that you lose when you're undergoing treatment, and then afterwards, like I said, the morbidities and the future that comes along, basically you're burning this bridge, and it's in the long term is going to cost you more money, cost you more time, more funds to try to be able to live a normal life. With the TULSA-PRO or any focal therapy, the great part about it is that you're not burning any bridges. Let's say you have a focal therapy, you're living a couple of years of your life, and later on the cancer comes back. You did not burn any bridges. You can get the treatment again, same treatment, focal therapy. You can get radical prostatectomy. You can get radiation therapy. But you have to look at it. Do you want to live the life that you're living right now, or you're willing to undergo drastic change because to get the cancer out? Does that make sense?
It makes perfect sense to me.
Yeah.
Any other questions, anybody?
I have one. Do you use PSMA to target the focal, to target to improve your outcome versus MRI or in conjunction with MRI?
No, PSMA scan is only you can acquire it in certain situations, and it goes by the guidelines because it's in a very expensive study as well. When you have a high risk prostate cancer, meaning more Gleason 4s involved, or any features that in your biopsy, like Gleason 5, or extreme features like cribriform glands, that's when you can go ahead and order a PSMA scan to make sure that it's not metastasized to other parts of your body. However, if you have a low risk prostate cancer or favorable risk prostate cancer with a low PSA, it's not necessary to get a PET scan, because if I'm going to go ahead and do surgery on you and remove your prostate, I never get a PET scan in that situation. It will never get approved. That's just the way our system is. After the treatment, you don't get a PET scan unless you have a high suspicion for recurrence or high suspicion for something that could have metastasized. But that comes into the patient selection. You want to choose the patients for focal therapy that they do not have any sign of metastasis. So you do not want to treat those patients. There's only certain criteria that you use the PSMA.
So let me, I'm not sure if I understand. Do you do a PSMA to make sure there's no extra capsular extension outside
Only,
the prostate?
only if it is indicated, meaning that
Because
you
the reason
have
I
high
ask is,
risk. I'm sorry.
the reason I ask is I think maybe a good amount of surgeries, have to be redone because, the cancer goes outside the prostate after the prostate is taken out. So, I think
Yeah.
maybe
So
you need to, maybe, more attention needs to be given to see what's happening outside the prostate.
even those patients that had metastatic feature, let's say 5 years later to else place, and they had prostate removed and they had the PET scan will not pick up any metastatic disease in patients that they're silent. That's just the way that the capabilities that we have. So, and also, this is the way that it goes with the social health. If we go ahead and obtain a PET scan off of every patient that has prostate cancer, we will not be able, neither one of us will be able to afford any insurance.
Yeah, but if you're that patient, would you want that to happen for you?
For me personally, in a certain criteria, if I get personally diagnosed with a Gleason 3+4 and my PSA is 5, I do not want a PET scan. It's not going to help me.
What I'm saying is, you said, I mean, people want the best for themselves. That's my point.
Yes, but it's not feasible to do that. We all want the best things for ourselves. I want to have the best living situation, the best medical care, best studies possible. But if you do that for everybody, then there's no money left for the people that they actually need treatment and the insurance pay for insurance. So it's an unnecessary study that is this is determined by a large population study. When we are recommending something for a patient to do, these are thousands of cases that you look at and you draw a scientific statistical significant result. That's how you recommend a certain study to a patient, not an individual based.
Right. Okay. Focal therapy, I understand, is considered investigational. What is the recurrence rate of TULSA-PRO and other
Sure.
modalities?
So in European countries, which are much ahead of us in the US, we are very slow to adopt new technologies. If you go into United Kingdom and get diagnosed with prostate cancer, Gleason 3+4 or 4+3, they don't talk to you about focal therapy. That's malpractice. So investigational for us in US is that we are not there like the confidence that they have the Europeans. We say investigational for that. There is a recurrence rate if you remove your prostate, if you do radiation therapy, if you get focal therapy. There are some studies, old studies, that had shown as high as 20 to 26% risk of recurrence. But that study did not include the appropriate patients that or the information of where they treated, how many times they were treated, what was the protocol that they used. What we use today is not similar what they did 5 years ago when they published that paper. There are some other papers coming out, some studies with some colleagues that if you choose the right patient with the right treatment, the prostate cancer recurrence rate is similar to radical prostatectomy.
Does anybody else have anything? Well, I thank you all for being here. This was a very, very exciting and enlightening presentation. And Doctor, we look forward to seeing you again. If no one else has questions, I will bid you a good evening and look forward to seeing you at the next Tuesday support group, 5 p.m. Pacific time.
Thank you very
On
much.
Zoom.
Thank you
you
very
all.
much.
Thank you,
Thank you.
guys.
Excellent
Good
presentation.
meeting everybody.
Excellent
Thank you so
presentation.
much. Thank you so
Thank
much.
you, Doctor.
Thank
All right. I'm here for you guys if you ever need anything. Thank you.
Thank
Thank
you.
you. Thank
Bye-bye.
you. Bye.
Before introducing our speaker, a quick word about the Prostate Forum of Orange County. The Forum is a group of men who themselves are dealing with prostate cancer and who want to support anyone else who is dealing with the disease. We do this by offering information, education and hope through our website, prostateforum.org, and through monthly support group meetings and presentations by experts. There are 2 online support meetings each month. The first, mainly for those newly diagnosed with prostate cancer, meets on the 2nd Tuesday of every month, and another meets on the 4th Tuesday of each month, mostly focused on advanced and recurrent prostate cancer. Both meetings are free and open to anyone affected by prostate cancer. In addition to these support groups, we also offer on most months talks by experts in the diagnosis and treatment of prostate cancer, just like tonight's presentation. Topics from these experts range from diagnosis to active surveillance to radiation, surgery, side effects, genetics, and other medical advances. You can learn about upcoming presentations at prostateforum.org/speakers or view previous presentations at prostateforum.org/presentations or on our YouTube channel at youtube.com/@prostateforumoc. To take advantage of these resources, we encourage you to sign up to receive announcements of meetings, presentations, and newsletters. And when you're ready, please consider helping us help others who are dealing with cancer. We're all volunteers, and we invite you to volunteer some of your time and expertise with organization, coordination, marketing, website maintenance, whatever you can. Whatever you can give will really help. And even though our volunteers are not paid, our expenses are very real. Your donations will help us to continue providing education, information, and hope to men with prostate cancer and their families and friends.